Hello. For this module, we'll try to evaluate the utility of ultrasound for vascular access. We'll talk both about central vascular access, although this area has been proven and is more commonly in practice. So we'll try to spend more time with the utility of ultrasound for peripheral vascular access. We know that vascular access is a vital procedure for vast majority of healthcare providers, and it has been demonstrated that these vascular access procedures are potentials for having significant risk. You can see here listed the potential incidence of complications associated with central venous access. Ultrasound has been demonstrated to reduce these complications when the provider is able to use it in a fashion and learn about the modality. In particular, I want to highlight, as we'll show in the future slides, the utility of ultrasound when it comes to central venous access and well as peripheral venous access is on several folds. One of the biggest folds is that it allows us to be able to see relative anatomy and decide the appropriate positioning via the external landmarks of where we should place our needle. So the idea of just understanding the location of the vein is very helpful when we use ultrasound technology. In addition to that, sort of the higher potential user and facile ultrasonographer would use ultrasound to be able to actually facilitate the actual catheter placement itself, meaning that they would use ultrasound to visualize the tip throughout the procedure and ensure that they are in fact in the vessel of interest, along with the ability of even visualizing the guide wire and its placement in the appropriate vessel of interest. Those are sort of the higher level of ultrasound sophistication. And you can see here the many ways in which ultrasound has proven its utility when it comes to vascular access. What type of probe do we use? Well, we want, since most of our vascular structures will be superficial, meaning that obviously we have to be able to put a catheter in that location, so they should be less than 8 centimeters deep, and that lends itself to the benefit of having the high-frequency linear probe. Remember, the high-frequency probe, somewhere around 12 megahertz, and most important, to realize again that the footprint of the ultrasound probe, the length of that footprint matches specifically on the length of the screen. So there's no increase in the footprint's coverage as you go further and further from the ultrasound probe. Key important component of using ultrasound for vascular access is always image orientation, meaning that you identify the indicator of the ultrasound probe and match it to the indicator of the screen interface. And this should occur every single time you use ultrasound for any procedure, whether it's diagnostic or procedural. Just a quick slide on how we can use ultrasound to identify artery versus vein. A lot of this is fairly intuitive, but when we get to deeper structures, it can be useful. Remember, the compressibility will be different in a venous structure compared to arterial. Also important to realize that when you place something such as a tourniquet, you expect that vein to get larger, but should have minimal effect on the artery. Similarly, when you have patient position changes, that should impact the venous structure, such as the internal jugular, but not affect the arterial structures as much. When you use color Doppler, very important to realize that you cannot look at the color of the color Doppler to designate artery versus vein, but you can use it to look for pulsatility. So more of a pulsatile flow pattern can suggest an arterial vascular structure versus venous. Two techniques to obtain vascular access with the utility of ultrasound. A transverse technique, in which you are seeing the transverse cross-section and of the vascular structure and looking for your needle tip to enter that. Or the longitudinal fashion, where you actually will put your ultrasound probe in the plane of the needle itself and visualize the entirety of the needle during the procedure process. Benefits of this are the transverse approach allows you to have surrounding structures in view throughout the procedure, but again, you're not seeing the entirety of the needle. Versus the opposite is true when you use the longitudinal approach. You're able to see the entirety of the needle, but you now no longer have a view of the surrounding structures. So let's just quickly talk about ultrasound for the internal jugular vein. Very routine technique. I won't go through all the verbiage here on this slide. But again, the key topic when it comes to the use of ultrasound for internal jugular venous cannulation is the ability of identifying the carotid and knowing the actual path of the internal jugular vein, therefore decreasing potential needle puncture attempts. This is one approach here of how you should potentially use ultrasound to facilitate the procedure itself, and I will allow this is also an iBook to read through this. Ultrasound image here showing the carotid and IVC, and again I would highlight the fact that the vast majority of initial users of ultrasound for any vascular access procedure is to help identify this relative anatomy and identify the location of the structure of interest relative to the ultrasound probe. The key thing I'd like to highlight though is that the next higher level of using ultrasound when it comes to vascular access procedure is developing a technique such that you'll be able to visualize the needle tip throughout the procedure. And there's two approaches for this. One is developing a fanning process. So you keep still a transverse cross-section of the vascular structure, but you fan with your ultrasound probe as you progress with your needle tip, such that you're always visualizing the needle tip throughout the procedure. Similarly, you could also do, or alternatively rather, you could do a longitudinal plane approach in which you could visualize the needle shaft throughout the procedure as well. So this is a cartoon indicating that fanning technique. As you proceed further in with your needle tip, you want to fan your ultrasound plane such that you're always in the needle's path. This is definitely one of those things that sounds intuitive, but it takes practice, and there has been publications of almost up to a 30% failure of detection of the needle tip, even with the use of ultrasound. Okay, so now let's go into the subclavian vein. Often initially thought of that the subclavian vein could not be, ultrasound could not be used for facilitating the cannulation of the subclavian vein. In fact, I actually do not believe this at all. In fact, I use this ultrasound very frequently for all my subclavian vascular access procedures, and I'll explain the process that we use for that. Important to realize that the subclavian vein is a continuation of the axillary vein, and with the ultrasound, you can see this continuation, and that will allow you to potentially find the most optimal area of site for access. And I will talk about this more as we go further, but I think one of the big utilities of ultrasound when it comes to subclavian vein access is that it allows us a much more lateral approach, and therefore potentially removing the risk of a pneumothorax. So standard positioning here for the subclavian approach is shown here. Traditionally, we have our dogma has reported the use of the middle thirds of the clavicle to be able to identify the location in which the subclavian vein goes under the clavicle and follows linearly into it forms this confluence with the internal jugular. However, again, I would like to show the utility of ultrasound to show where it could be very useful by doing a more lateral approach to the subclavian venous cannulation. This again is the standard procedure for non-ultrasound guided subclavian vein approach. And so we'll first talk about how ultrasound can be added to the standard traditional approach, and I'll show you that here. So there's a cartoon showing the initial placement. We see the subclavian vein diving under the clavicle here, forming that nice routine pathway that we use regularly that we rely on regularly to cannulate the subclavian vein. Very important to realize that the reason why we really kind of focus on this medial aspect is because this area is fairly consistent in all patient body habituses. However, the location of the transition of the axillary vein to subclavian vein is highly variable. Some have very high arching areas of transition, meaning that they even potentially can go above the clavicle, or it can have much more of a linear shot. And so whether this occurs in this fashion or this fashion is one of the key differences, and makes the lateral approach to the subclavian vein very challenging without ultrasound, because you literally have a large area where you would not be able to know without any relative anatomy that could show consistency. So that's why historically we've really targeted this area. But again, I'd like to highlight the fact that ultrasound can help identify this pathway and provide a new avenue of where we potentially could place our subclavian vein catheters. This again just showing how we would take with the clavicle, having our needle approach superficially underneath the clavicle as we can, so that we cannulate the vein artery behind that, and not that much further below. We have the lung pleura and the wrist for a pneumothorax. Here's a ultrasound image of just that, placing the ultrasound probe here transversely over the clavicle so that the top footprint of the ultrasound probe is on top of the clavicle. We visualize the connective tissue here, the subclavian vein diving below this. Again, this is at the proximal medial half of from the clavicular line. We see our vein, we see the artery, and then you can see the lung pleura not that far away. This cartoon shows the potential of other avenues of approachment, and I'd like to highlight again the lateral approach when we use ultrasound. And in the end of this talk, we'll go on to the demonstration, and I'll demonstrate to you the potential utility of ultrasound to allow us to have our needle approach much more laterally than the traditional areas of access. Okay, now going on to femoral vein cannulation. Again, this cartoon just talks about the relative anatomy here. Very important to always remember the concept of navel, meaning that the vein is in fact medial to the artery, and so ultrasound has really allowed its utility to be able to help differentiate the femoral artery from the femoral vein. As you can see here in this picture here, you placing the ultrasound probe in the inguinal crease, allowing us to have quick identification of the artery and vein, I think is one of the biggest useful utilities when it comes to the femoral vein cannulation. You can see also the nerve here. So now let's spend some time talking about peripheral venous access, and I think this is the area where ultrasound is going to have a growing area of utility. Many folks have the ability of honing in their skills for the distal venous access and any vein that we can visualize. However, there are deeper upper extremity veins that are not able to be visually assessed, but with ultrasound they allow us to be able to get pictures that would potentially allow us new avenues of where we could gain access. So again, I would encourage this. Again, shows you how to differentiate arteries and veins, and this is also listed in the iBook. Just for review, we're very facile with the superficial dorsal veins, cephalic veins, and basilic veins when it comes to the distal extremity. However, when it comes into the upper, as well as the lateral and medial cubital veins, however, when it comes into the upper extremity area, those locations require ultrasound to get a an actual visualization of these venous structures. And these are commonly where PICC lines are placed, and I'd like to demonstrate how ultrasound is very useful to identify these structures. So the three veins that we were talking about: cephalic, basilic, and brachial veins. Those are the areas that we'll talk about. So this cartoon just breaks down just the venous structures themselves. The cephalic runs up on the anterior aspect of the arm if you're looking at this pronated position, and it is very superficial, although still hard to visualize in some patients, and so ultrasound can be very useful to identify that path. As we work more medially, we'll come across the brachial vein, which will be along the brachial artery, and we'll show you a slide on this. And I want to highlight the key thing about the brachial vein is that it shares a connective tissue sheath with the artery, and that allows the sheath to allow that area to have some tensile strength. So even though it is deep and close to artery and nerve, there is the potential of cannulating this venous structure, actually placing a guy wire into the venous structure, because there is some tensile strength because of the sheath that is surrounded by those structures. And finally, the basilic vein, which is the largest out of the three veins. The most common area for PICC line placement is the basilic vein, and this is a wonderful vein to learn how to ultrasound, because it can be one that can allow for large gauge access, and is, again, as I mentioned, the largest vein in the upper extremity, and the routine vein that's most often used for PICC line placement. So here, this is on the medial aspect, and again, we'll talk about this when we do the hands-on demo on the location of this vein, but it is the most medial aspect. Techniques, again, for approaching a peripheral venous access is transverse approach and the longitudinal approach. Very important to put the least amount of pressure you can with the ultrasound probe, as you do not want to cause occlusion of that venous structure simply from the pressure of the probe. And you also want to make sure that you're always visualizing the tip of the ultrasound needle, and of the catheter needle when you have your ultrasound plane. And when we'll talk about that here, you see always thinking when you hold the ultrasound probe of what the ultrasound plane is, such that you can adjust this plane so that it matches your needle tip. So very appropriate to have this sort of positioning initially when you're cannulating, when you're entering the skin. However, once you enter the skin, you want to work on having your ultrasound plane much more along the side of the shaft of the needle. And so I'll try to show that in this cartoon here. So you see now this ultrasound probe we've fanned the ultrasound probe such that we are allowing us to visualize the needle tip throughout the entirety. And so on this simulation video here, you can see that we've now visualized the needle tip throughout the process of scanning and entering the vein. And so that technique of fanning, a very important approach of starting initially here vertically and then changing the ultrasound probe such that we're able to fan it into the cannulation is the key component. You can see that here. Once we've gained access, then we just say a similar process of connecting the sheath over. But the fanning technique is very important to practice for deeper peripheral venous access. Obviously, the concern of not doing the fanning technique is that by keeping the ultrasound probe stationary, your ultrasound plane itself is stationary, and you may actually miss the needle tip here. So as this cartoon shows here, what has happened is that the needle tip is actually through the vein, but your ultrasound image will actually look as if the shaft is in the venous structure itself, simply because you haven't adjusted the ultrasound plane to follow the entirety of the needle, in particular the needle tip. So again, approaching that, the longitudinal approach shown here, again, you're just placing it such that the vein is over the ultrasound plane and visualizing that as it goes through is the next step. Here's some also tips when it comes to venous access. The other hot point I wanted to mention that I didn't state was the subclavian vein. It is reported that the left side, left upper lobe, sits a little bit higher in the chest, and so potential pneumothorax theoretically could be a little bit higher on the left side compared to the right. We'll now go on to the hands-on demonstration. Okay, for the hands-on demonstration here on peripheral venous access, we're going to use first location of the ultrasound probe. We're going to place it in the antecubital fossa, and we're going to try to identify, we see in the middle of the screen there is a median cubital vein, and we're going to adjust our ultrasound probe just by sliding it more medially to identify the brachial artery, and we can see that on the left side of the screen there. And once we identify the brachial artery, we're going to now slide up to the mid portion of the upper extremity, just past the distal head of the biceps. And from there, at that point, again, at the mid part of the upper extremity arm, we're going to see two venous structures surrounding the brachial artery. And so the brachial vein is the one that's proximal right next to the brachial artery, and we'll apply some compression to identify the artery versus vein there. You can see that in the middle of the screen. So we see the brachial veins associated with the brachial artery, again, just below the brachial artery in this ultrasound image. And to the left of that, we see the basilic vein. And we can see that's now we're actually applying some compression to. So adjusting by sliding our probe more medially or down to the patient's bed, we'll put that in the middle of the screen, and we can see the basilic vein now sitting in the middle of the screen there. And this, you can see that it's the largest diameter vein and the most frequent access site for PICC lines. Finally, to identify the cephalic vein, we're going to slide back to the most anterior aspect of the arm, just around the head of the bicep, and identify a very super venous structure, which we see here now. Again, so if you identify now, adjust your patient's position so that their thumb is pointing up, and follow that head of the bicep until you find that venous structure. Very important when you're trying to identify the cephalic vein to realize that it is going to be very superficial. Definitely within the first half to 1 centimeter, you'll be able to identify this vein, and now we see it nicely in the middle of our screen here. Again, very superficial, very easily to be compressed, but ultrasound really can help out with the identification. Okay, great. Let's review how ultrasound can be useful for subclavian vein access. So you'll notice that the ultrasound probe is placed traditionally as you would for the initial traditional approach with the subclavian vein, right at the deltoid pectoral groove, right at the point of the distal part of the 1/3 of the clavicle. And we can see that the clavicle is on the left side of the screen there. That's the hypercoic structure. And we can see actually the subclavian vein shown here in the middle of the screen, right before it goes underneath the clavicle. As you can see here, I'm watching as I slide my probe more immediately. You can see, in fact, that subclavian vein going underneath the clavicle. And so this approach can be useful to identify the subclavian vein for a subclavian approach, but I'd like to highlight the area of hypoechoicness on the bottom right-hand side of the ultrasound image, which is in fact the lung pleura, which again highlights the potential concern when it comes to the subclavian venous access procedure. One of the benefits of ultrasound, as we talked in the didactic portion of this, is that you're now able to potentially access the subclavian vein much more laterally, even perhaps at the level of the axillary vein. And so I'll demonstrate that. We're just going to slide our ultrasound probe with the subclavian vein in the view and slide more laterally to the point where we're able to identify the venous structure in a much more lateral approach. This is really one of the benefits of point-of-care ultrasound when it comes to the use for subclavian venous access, is that it allows us to potentially go into an area where we're now far away from the lung fields and make the access site of the subclavian vein potentially much more safer, at least from the point of potentially causing a pneumothorax.